Yeah. Good evening, everyone. So, welcome to this 100th
Wait,
Fertility
wait.
Master.
Yeah, now live.
Yeah, good evening, everyone. So, welcome to this 100th Fertility Masterclass series, which we had started almost like 1.5 years back, and now we have reached this 100th class. And today's topic is IUI stimulation for low AMH cases. So as we see, there are so many cases nowadays that we are all seeing where even young people, young women have come with low AMH, and it is very difficult to convince them to do any form of treatment, because when they are of less than 30 years, it becomes more and more difficult for them to digest the fact that there is something going on inside their body where the fertility is going down, because they will be totally asymptomatic. So these are one set of patients where it becomes challenging for us to hold on to them, especially when we don't want to escalate the treatment to an IVF. So IUI offers a very good in between kind of a treatment option, and we will discuss today about the induction protocols for such cases, where there will be many practical points which will be discussed. So over to you. Later on, we can discuss as to how we go ahead.
Okay. So just to remind to everybody, this can be a little long class of approximately 15 to 20 minutes. Second, it is very important to understand that in today's practical situation, especially when there are so many fertility practitioners in and around, what is going to happen is that in such type of cases, whatever ovulation induction protocol we follow, most of the times we will have to give the patient an outcome despite thorough counseling within the first 2 to 3 cycles. That means if in case you are putting somebody in the fourth IUI cycle or the fifth IUI cycle, the probability is very high that the patient is not going to stick to you. Okay, so that is the first thing you have to understand. So whatever you do has to be excellent from the first cycle itself. Okay. And the third thing, which Shilpa madam actually pointed out, that in majority of the situations like this, you have low AMH patients in young women, you have low AMH patient in the age group of around 30 to 40, and then you have low AMH patients more than 40. See, the biggest problem is in convincing the two spectrums which are at the away from the standard deviation, means less than 30 and more than 40. Less than 30 do not want to basically believe that anything is wrong, as madam has said, and as a result of which, they may not want to switch to IVF. Quite a lot of times these days, especially in today's time and age, apart from dealing with stupids, you are also dealing with people on social media who will end up saying that nothing happens in low AMH, even if AMH is 0.00000000001. People can have 45 children. All these types of things will come out, and then people will believe that. The other spectrum, which is very difficult to treat, is where you don't want to do an IUI, especially when the female partner's age is more than 37, 38, 40. AMH is low, but they are married very recently. And because they are married very recently, them thinking about IVF is going to be a very big jump for them. And that much practicality does not exist in a common life situation. And as a result of which, these two spectrums are going to be the toughest. Okay. I'm going to be switching to the screen sharing, and I'm going to be very quickly trying to draw all what we have to understand as far as this topic is concerned. So you can see the screen, right?
Yeah.
Fine. So what is important for us to understand is that whenever we are trying to stimulate low AMH patients, the first thing about all of this is counseling. Just remember, in a low AMH patient, what is important for us to understand is that low AMH basically indicates to all the patients as well as to all the practitioners that basically the response to stimulation can be poor. Okay, it has got usually no great correlation with the success rate of a particular procedure, but the response to stimulation is going to be on the delayed side. Second thing I want to clear very, very importantly in all these patients. Okay, despite all the fancy things which people want to try, like CoQ, People want to try DHEA. People may want to try certain additional molecules which they think are absolutely fantastic. But remember, none of them have a major role as far as increasing the low AMH on a permanent basis is concerned. The only thing which may have certain amount of benefit as far as the patient perspective is concerned is testosterone gel. Okay. Testosterone gel, preferably given one cycle before, preferably given two cycles before, okay, is going to benefit. But again, you cannot have testosterone gel benefiting 100 out of 100 women. Testosterone gel may benefit a particular percentage of women. The exact science behind that is not known. But remember, it raises the androgen microenvironment. So because it raises the androgen microenvironment, it allows more primordial follicles to be recruited. Okay, and because it allows more primordial follicles to be recruited, it may give you an outcome if your stimulation is good. So again, we come down to how well we are stimulating, as we mentioned a while back. All right. So do not try your hands into any of the other fancy things which you think really work, because none of them actually have been proven to be of any scientific benefit. And I think it is even important for patients to know that this drug, which everybody likes, which is folic acid, has got no role in AMH. All right. Now, what are the important prerequisites which all of us have to keep in mind when we are trying to stimulate the patient? Is basically husband semen analysis has to be absolutely normal. DNA fragmentation index has to be less than 25%. Fallopian tubes have to be open. You cannot have one fallopian tube with an AMH of zero point 0.3 with a previous ectopic, previous three abortions, weight of 95 kgs, and then expecting that first cycle only IUI will succeed. All those things are not going to happen. Have very strict and have very, very defined criteria and have a low threshold for IVF as well. Okay. One thing which I have typically eliminated here is because we are discussing poor responders. So basically, we are understanding that AFC is going to be less than 6, AMH is typically going to be less than 1. Okay. The one thing which is very, very important is definitely the age of the patient. But here, when we try to discuss the spectrum, we will try to discuss everything. Okay. One more very important thing I think all of us must rule out in such type of situations, especially in poor responders, is rule out all other endocrinologies. That means TSH is supposed to be normal. Prolactin ideally is supposed to be less than 20. Get your TSH level to less than 2.5. Hemoglobin is supposed to be more than 11 gram percentage for the female partner. USG 3D of the pelvis is supposed to be normal. All these things are very important prerequisites, and only then you allow these patients to go ahead with IUI. Okay, you can't, again, do not try and experiment with this. I just saw one patient today. She had a 12.2 centimeter intramural fibroid. Okay. And she has tried 17 IUI cycles only. Okay. So what is going to happen is the IUI was done correctly, but the problem is the fibroid was not taken out because somebody has declared that if a fertility patient is there, you don't need to do myomectomy. The only thing is that guideline has not been conveyed correctly to our fellow colleague, because it is stating that if the fibroid is less than 4 centimeter, okay, then you may experiment, preferably if it is not distorting the cavity. Okay, so the guideline was not communicated correctly to the practitioner. So even 12.2, he went ahead and did 17 IUI cycles between four consultants. So maybe that is the situations, which keep on happening. These type of girls will get pregnant naturally only. Just remove the fibroid and they will conceive in 3 months. Okay. Now coming to the protocols, because after having discussing all these things, only then the protocol is going to be very important for us. So here is something which you need to keep in mind. Okay. See, if you look at the ovary, and I am drawing around 5 follicles because antral follicle count is going to be just 5. This is one of those situations where you may have a cohort which is irregular, because the patient is having a low AMH. In an irregular cohort in IUI cycle, do not hesitate to give pre-treatment antagonist. We have discussed this in our first masterclass. You can go back and see what is pre-treatment antagonist. After you do that, we have made a rule that we follow a standard stimulation of giving letrozole 2.5 plus HPHMG of 150 international units. Now, usually doing this for 7 days. Okay, the answer is 7 days, not 5 days. The answer is giving letrozole and HPHMG together, not in a sequential protocol. The answer is starting both of them together either on day 2 or day 3 of the menses. You give it for 7 days. So that's, I'm just drawing 7 injections. And after 7 injections, you will normally end up seeing that you may have in a situation like this approximately two or sometimes three follicles which have become dominant follicles and have somewhere reached between 13 millimeters to 15 millimeters in size. Now, after this has occurred in a patient with low AMH, either you can simply wait and watch because the estrogen is usually going to be less than 200 because you have given letrozole, and if the estrogen is usually more than 200, then you can add something called as half dose antagonist. Now this half dose antagonist also we have discussed many times before. Once the follicle reaches somewhere between 19 to 21 millimeter, once they become proper dominant follicles, that is when you trigger. And the only trigger which you should be giving in these patients is 10,000 hcg if you want to do IUI, which is to be done usually after approximately 40 to 42 hours of giving the trigger. Kindly do not give GnRH agonist as a trigger. Kindly do not give dual trigger. Kindly do not do anything like that. All right. This is very important to standardize the protocol, irrespective of the age of the patient, because in an IUI, usually nothing should try to go wrong with the patient. No addition of serum, is no addition of estrogen tablets, no addition of multivitamins, no addition of growth hormone, no addition of LH, no addition of low dose HCG. Low dose HCG can be tried. I will be discussing that as a separate protocol. But if you want to study low dose HCG is an excellent protocol. But this is not the class where we are trying to describe it. Otherwise, apart from this protocol, if the patient is very poor and you want to save cost, then remember low dose HCG is an excellent protocol provided you know how to do it correctly. The problem is not the protocol, the problem is we don't understand how to do it correctly. All right. As far as the preparation of the semen is concerned, you can do the standard double density or swim up, whatever you like the most. Some people have also shifted to using microfluidic, but microfluidic, the only problem is the alicot is slightly lesser in size. Okay, but that is something which you have to rule out with your biologist or your embryologist, and you need to keep that in mind that in a situation like that, whatever you do, try to obtain an alicot between zero point 0.6 to 0.4 ml. The standard IUI preparation is going to allow a standard insemination time of approximately 6 to 10 minutes. Once that is done, all right, make sure that you can give any type of luteal phase support. The luteal phase support is very straightforward. So we typically give the luteal phase support in the form of either progesterone gel 8%, or we give the patients Dufaston, which is an oral tablet, which is given as 10 milligrams twice in a day for the next 14 days. Now, usually when you do this in a patient with low AMH, if the age is less than 30, then you can have a success rate of approximately 10 to 15%. If the age is more than, I mean, between 30 to 40, then probably the success rate drops down to approximately 8 to 10%. I do not recommend this protocol to be followed in women with an age group of more than 40, because there the success rates are going to be less than 5%. Now, all this is some biology and all this is something which we all understand. But I personally think having a standardized protocol like this is going to be something which is going to be exceedingly beneficial if you are to practice this with a very low threshold of doing IVF. You cannot have a you cannot have a system where you are following this protocol endlessly. According to me, 2 cycles or maybe 3 cycles is more than enough. If in 2 or 3 cycles this does not work, kindly make sure that the patient goes to IVF. Okay. Remember one more thing. We all understand that because we are all extremely knowledgeable, we want to try out different protocols for patients. Never ever do that in IUI cycles. Because in doing it in IUI cycles, most of the times IUI cycles are not going to be continuously monitored by the primary consultant. IUI cycles are going to be monitored by a lot of people, by you, your associates, your fellows, whatever. Everything regarding an IUI protocol has to be standardized, because if you do not standardize your IUI protocol, then one thing will happen, that the patient will lose confidence in the first IUI itself. The patient will think that two people are talking two different things. and that should never happen. We have a policy here in our unit that whenever we are doing semen preparation for IUI, once the post wash count has been produced, the post wash counts are usually shown to the male partners before the insemination is done. Probably it does not help in the success rates. It just boosts the patient confidence and gives them that assurance that okay, the sperm which was used was of the highest or the best possible quality. Please do the counseling that you cannot see the egg, you can only see the follicle. This follicle in a patient with low AMH can also be an empty follicle despite the hormones being normal. And as a result of which, IUI cycle, you are leaving everything to nature. Only activated sperms where acrosomal reaction has occurred is being injected inside the uterus, as a result of which the potency time reduces to approximately 2 hours. And usually in a situation, if the ovulation has occurred, that sperm is supposed to go and first fertilize the egg. That egg is then supposed to get fertilized, divide, form blastocyst, generate an endometrial to embryo crosstalk and get implanted. All these things are then driven by nature. Okay. As a result of which, if your stimulation has gone wrong and if the window of implantation is skipped, despite the embryo being formed nicely, there will be no implantation which will occur, which will further reduce your success rates. The commonest problem which people think have or they have in their mind is that in a situation like this, what if the patient goes for OHSS, right? So please remember one thing, the possibility that this is going to go into OHSS is going to be very, very, very less. Already patient has low AMH. I do understand the fancy of listening to people and trying clomiphene citrate for low AMH and trying a combination of clomiphene plus letrozole, trying letrozole and HPHMG every alternate day. I understand all this is done by people to save the cost, but apart from saving the cost, you are achieving nothing because you will save the cost, but you will lose the patient because this does not standardize your outcome and this does not give you the desired outcomes of your IUI. Okay. So, with that, I think I have covered almost everything which can be covered in this particular topic, and I will be happy to answer a few questions.
So, do you start the stimulation from day 2 or day 3, or does it make a difference?
No, it does not really make a difference. Day 2 and day 3 does not really matter. If in case we require to give pre-treatment antagonist to patients, then only we may wait for a day or so. Otherwise, we need not wait for anything.
Okay, so if you see a cyst on day 2 or day 3, which is a very
Aspirate
common
it.
thing in low AMH,
Just
so even
aspirate.
aspirating it may be difficult in some cases because they have to agree it is like a procedure. So aspirating, if it is not a choice, can you give one antag and then start it?
No, give two antags. Matlab give 0.5 instead of 0.25.
5, yeah. So, in case if you're talking about low AMH in different age groups, so the toughest group is about 37, 38 is what I feel, where like,
Yeah.
you know, the success rate is very poor because we take age and age as a criteria, which is very, very important. So, in these situations, do you think like, you know, I mean, counseling is a very important part of this whole exercise where,
Ideally, they should not go ahead and do IUI only. They should only
yeah.
do IUI if they are very adamant about it.
Mhm. So, in case if you think that follicle is going ahead than the endometrium, and endometrium is lagging, which
Hmm.
happens very often in
Hmm.
low AMH cases. So,
Yeah.
one is giving half dose antag.
Yeah.
So, do you add estradiol, valerate to that and try and improve the endometrium?
Never do that.
And is there any particular number of days that the stimulation has to go on? Because sometimes we see a
7 days
follicle
is
on,
standardized, madam. I mean, you
yeah.
want, you can probably give 1 day more, but 7 days is like absolutely, absolutely standardized.
But if you see a follicle on day 8 itself, which is about 19 millimeter, 20 millimeter,
Hmm.
so you just go ahead and trigger, or do you want it to go on till like, you know, day 12 and then you
No,
have
no,
to.
no, no, no. If it is 17 to 18 and endometrium is good, just go ahead and trigger it. No problem.
So, in cases where we see that these antral follicle counts keep changing month on month,
Yeah,
so in these situations, when you think that like, you know, you want to do only 2 cycles of IUI and then you have to do an IVF. So in such situations, do you actually see an AFC and cancel the cycle and tell them to come back the next cycle?
doesn't
Does
really
it
matter,
really?
madam.
So I mean, if you are giving them testosterone gel, so do you ask them to come back after 4 weeks, 8 weeks? How do you do it?
Again, it doesn't really matter, to be honest with you. Even day 21 of the previous cycle is fine. Trust me.
So there are questions in the chat box. What is your view on ovarian PRP in low AMH? I mean, do you do
So
it?
I don't think I'm qualified enough to give my view. I will give you what is the view of the world, right? What is literature stating? Literature is absolutely straightforward. Ovarian PRP has got no role.
Okay. So any role of HCG support in luteal phase?
No role.
E2 levels, how to monitor when we don't do it. So is there any cutoff of AMH below which IVF is preferred? Not really. It
No, there
is
is nothing like that.
nothing like that. So can half dose antag be given without checking E2 levels? Yeah.
Yes, you can, but then I have the facility to do it in-house. So I do it very fast. Everything comes to me in 1 hour.
Below what endometrial thickness not to give trigger?
5.5.
Hope we get the record. Okay. How is FSH window maintained when you stop HMG plus letrozole after 7 days
You need not maintain this. The follicle is going to grow on its own.
on its own? So when do you cancel cycle? I mean, say you have stimulated,
No
you
response to stimulation. That will happen if the AMH is less than zero point 0.3 in quite a lot of situations.
yeah, we see that. So in these situations, do you think like, IVF with dual stim will be a good choice if three cycles
Slowly, we
take?
are not preferring to do dual stim, ma'am. We are shifting towards random stimulation in low AMH
Mm.
patients. Whenever the patient comes and wants to do IVF, if the AMH is low, you can go ahead and do random stimulation. You need not think, wait, or worry about doing a particular phase of stimulation. It does not really matter in low AMH.
So in cases where AMH is less than one, so what is the success rate that you tell the patient that they will have
As I
before
told,
starting?
IUI is we tell IUI as 10 to 12%. We tell IVF as approximately 25 to 30%.
Yeah. So in cases like this where AMH is low and you feel like, I mean, you don't want to do ovulation induction, is the IUI a good choice? Or rather you do it as a stepwise manner where you start with ovulation induction for 2, 3 cycles and then go for
It
IUI?
these days, madam, it depends on patient preferences only. And
Yeah.
quite a lot of times, many intelligent patients are straightly ready to go ahead with IVF.
Hmm. So on day of IUI, if the follicle is not ruptured, so how do we do it?
If you have given 10,000 HCG trigger, then don't bother about rupture and all these things. No need to give it again and again. You will skip the window. Just go
Hmm.
and do the IUI, please. Do not try
Yeah.
to document rupture at all the times. It is not mandatory.
Yes. Yes. So people keep changing protocols. So if IUI first cycle with Letros HMG doesn't work, then they go for CC HMG
No
or they
role.
go
You
for
should not,
CC.
like, I have heard people who have told that IUI results with Rec FSH are better. Nothing like that.
Yeah.
IUI results are the same everywhere. IUI result is a game of sperm preparation and how well that sperm has gone and fused with that egg, fertilized the egg. That's it. Even if it is letrozole CC or natural cycle IUI, that is that cute little trendy thing that oh, we just do natural cycle IUI. Not that it makes anybody pregnant, but you will feel very happy doing it. And
Yeah.
it doesn't really matter.
Yeah. Okay. I think we'll take the rest of the questions on
So I would like to
WhatsApp.
request all the people that if in case you have so many questions, please ask them on Telegram. My WhatsApp is going to stop from the next week onwards, and I have already declared it. So I would humbly request everybody to join Telegram and ask your questions there. Probably I'll be in a good position to answer your questions. Thank you so much, and a big round of applause and appreciation to Dr. Shilpa GB for moderating 100 masterclasses. That itself is a very big thing.
Thank you so much. Thank you, everyone. Thank you for